Welcome to this session on the importance of early recognition of interstitial lung disease as a practical strategies for the radiologists. My name is Brett Elliker. I'm joined by two distinguished speakers, Dr. Mary Salvatore and Dr. Joshua Solomon. And our focus today will not only be on early recognition of interstitial lung disease, but also the multidisciplinary approach and how important it is in approaching these patients with interstitial lung disease. And so again, welcome. And I want to briefly go over the agenda before we get started so you know what to expect. We're going to have three sessions to today's agenda. The first will be a virtual workshop led by Dr. Solomon that's focused on recognizing signs and symptoms of ILD and the importance of early diagnosis, followed by a second workshop led by Dr. Salvatore on the key components to an accurate diagnosis of ILD, interpretation of HRCT imaging in the context of the multidisciplinary approach. And then lastly will be a case presentation of Virtual Practicum that I will lead that will present an interesting case and present some of the challenges that we face in the approach to interstitial lung disease. And there will be an opportunity to ask questions to the faculty after each presentation. So with that, I will turn this over to Dr. Solomon, who will focus on recognizing signs and symptoms of interstitial lung disease and the importance of early diagnosis. Dr. Solomon.
Great. Thank you for that introduction, and thanks to the organizers for inviting me to talk about this incredibly important topic. It's a pleasure and an honor to talk to radiologists too, as you're such key components to the diagnosis of ILD that we really would be nowhere without you. So I'm honored to give this talk. I'm going to talk for about 15 or 20 minutes on the importance of early diagnosis, but starting with a general talk on what ILDs and how we look at them and how we go about diagnosing them. And I'll end this talk with some discussion on the current therapies. So there's often confusion around the diagnosis of ILDs and what ILD is. And I know it's confusing for us and it's confusing for patients too. So we characterize ILDs by having an abnormal interstitium, so the connective tissue disease between the airways, and they have to have either fibrosis or inflammation, and they often have both. They can also include airways disease in addition, but at a minimum they have to have interstitial involvement. Some classic ones that will also involve the airways include hypersensitivity pneumonitis and sarcoid. They can have a concomitant airways disease. The most common one we see is IPF, and that's about half what we see in our clinics, and I'll talk more about IPF. And these patients will present with kind of the insidious onset of cough and breathlessness. And it usually takes place over months. Patients who get short of breath over a week or two, that's not really a clinical scenario consistent with interstitial lung disease. It's usually more insidious, and that cough is dry. It's usually a non-productive cough. Invariably, when they progress, we will hear crackles on exam, and so those are really crackles are never normal. So what we always stress to physicians who are seeing these patients, when you hear crackles, you have to work that up, and they will invariably have that. It's a sign of fibrosis. And a percentage of them will have clubbing. So if you have clubbing present, it's helpful. If you don't have clubbing, it doesn't mean they don't have interstitial lung disease. They're difficult to diagnose for a number of different reasons. First off, I think it's not well known that there are a large number of interstitial lung diseases. There are a few that dominate our clinic, but if you really look at it, there's over 100 different disorders. And with such a diverse group of disorders, sometimes getting that specific diagnosis can be a challenge. They have similar symptoms, similar physiology. So, the physiology for most of these is very similar with a restrictive pattern. And there's only a number of radiographic patterns that we see in spite of there being over 100 disorders. So these similarities make it difficult to discern between the different disorders that we see. And the nomenclature can get quite complicated. We have a lot of acronyms that we use, DIP and RBILD, and I think when you throw a lot of these acronyms in, it really can be quite confusing. In addition, patients will often spend time in the community before they come to us, and the reason being is these are often diseases of aging, so we see this in patients who are in their 60s and 70s, and if you're in the community and you're short of breath and you're in your 60s, ILD is not the number one diagnosis that people are going to be looking at, right? It's very common. Common things being common. Heart disease is a common misdiagnosis, and then a lot of the patients we see are smokers. And if you're a smoker in the community and you're short of breath, COPD is usually what you're going to get diagnosed with. And so if you look at it, patients spend about 6 to 18 months in the community. before they get to the ILD doctor or the pulmonologist, and they often get misdiagnosed. And so half of them will have one misdiagnosis, and a third of them will have 2 or more misdiagnoses. And those are commonly asthma, pneumonia, bronchitis, COPD. And so a very typical scenario is a patient is short of breath and they go to a cardiologist and get a full cardiac workup. And then they eventually come to see me in clinic, and it's usually somewhere between 6 and 18 months. This is a great schematic for really looking at the different contributors to ILD. So ILD is a broad category. These are the different categories of causes. And so I think this is helpful to run through briefly so you understand how we group these interstitial lung diseases. The most common one is IPF. That's at the bottom there, and we'll talk more about that. The second and third most common is HP and connective tissue ILD. So HP, hypersensitivity pneumonitis, is an allergic reaction to something in your environment. It's common in the ILD world, and it's usually an exposure to some organic antigen in the environment. Birds cause it, so the bird fancier's lung is a subtype. We see it from moldy hay, and we see it from very common things like down comforter and down pillow. And so it can be very difficult to diagnose because sometimes the precipitants are subtle, and the radiographs also can have various different patterns. So it's sometimes quite difficult to diagnose. But when you look hard for it, you'll find hypersensitivity pneumonitis. Another one of the ILD categories is connective tissue related ILD. All the connective tissue diseases can cause ILD, every one of them. So if you have a connective tissue disease and you have some radiographic abnormalities consistent with ILD, they are most commonly related. The big 3 to remember are systemic sclerosis, which can be seen 70 to 80% of those patients will have ILD. Rheumatoid arthritis is about 30 to 40%, and then polymyositis, dermatomyositis is also lower down around 20 to 30%. But those are still big numbers. And then when you get to things like lupus, it's much less common but still present. So connective tissue-related ILD is a big category, and to make that more complicated, most of those patients, most of the connective tissue diseases some of them can present with their interstitial lung disease first and then develop their connective tissue disease later, making that diagnosis a challenge. Non-specific interstitial pneumonias that are idiopathic, that's a smaller category, but we still see those. A lot of those end up being a connective tissue disease when you look hard for it, but that's a category. And then no matter how hard we work at it, we still have an unclassifiable category. And it can be up to 1 in 5 patients, and that's a challenge. It's a challenge both for us and the patient, not to get a diagnosis, and therefore not knowing what the prognosis will be and what to treat them with. And there's a lot of different. It has to do with histology, and sometimes histology doesn't match with our radiographs. So we work hard on that unclassifiable group, but no matter how hard we work, that's still a significant number of patients. So IPF. That's about 50% of what we see. So half of what walks in the door of an ILD clinic will be idiopathic pulmonary fibrosis. It is a very specific diagnosis. It is a chronic progressive fibrosing interstitial pneumonia. So it progresses. It does not stay stable. And it's chronic and it develops over time. It occurs primarily in older adults. Older adults means 60s and above. IPF does not occur in a 40-year-old. And so that does help somewhat limit the differential when you see a younger person come in with radiographic abnormalities. So it's a disease of aging. It is limited to the lungs. This is not a disease that has extra pulmonary manifestations. And as we're going to learn a little bit later, it's defined by certain criteria. So a radiographic pattern, and when that doesn't fit, we do biopsies, and there's histopathologic patterns. And so it has a specific findings both on radiograph and pathology. And unfortunately for patients with IPF, all progression is permanent. So when they lose lung function, they don't get that lung function back. So this really starts to get to the point why an early diagnosis is critical. If we wait on these patients and we don't notice it early, or we wait to treat these patients and they progress, they won't get that lung function back. So the minute we think it's IPF, we need to be on top of this, and they need to see a specialist, and consideration should be given for directed therapy. Important to note is that even mild IPF progresses. So there is a common misconception that I still see a lot that, this is mild changes, it's early in the course of disease, Let's sit on this and let's wait. Well, they progress just at the same pace as patients with moderate to severe disease. And so again, another push towards getting an early diagnosis in these patients. Even if they have mild disease, we should really be following up on these patients and considering therapy. A challenge for the clinician and a bigger challenge for the patient is that it's really difficult to predict a disease course. This is a schematic that's been around a long time that I often will draw in the clinic room when I'm talking to patients. We know you progress, but we don't know where on this graph that you live. This rapidly progressive course, so the purple line, that's uncommon. Luckily for patients, we don't see that a lot. It's rare that we'll see a patient come in and just really fall off the cliff and have a rapid progression to death. That used to be called Hayman-Rich syndrome. We don't see that a lot. What we tend to see is a gradual decline over time that has acute exacerbation. So patients will be declining and they'll have an acute exacerbation, which is a kind of a flare of this interstitial lung disease. They will have a decline in their lung function. They'll never regain that lung function, and they will continue to have these acute exacerbations over time. Now, unfortunately, when you first hit the door of our clinic, there's no way we can predict your trajectory. We do know if you progressed in the last 6 months that you can continue to do so. So really changes over time are helpful, but at the visit 1, it's really hard to tell. I do think that in the near future, we'll be able to check a panel of biomarkers that'll say you're at risk for progression, but right now we don't know. But what we do know is you do progress, we just don't know the rate at which you do so. IPF doesn't have a good prognosis. Its 5-year survival is somewhere around 3.5 to 4 years. That's a median survival. Keep in mind that is untreated, and that's when patients are diagnosed after bouncing around the community with shortness of breath. What we're seeing these days, and you all will be aware of this, is that patients are getting CT scans for a number of different reasons. With lung cancer screening, patients who go into ERs will often get ruled out for a PE. And so when we find early disease, their prognosis is better. We're just catching them earlier before they actually have symptoms. But if you are symptomatic and you come to my clinic and we don't treat you, your survival is about 3.5 to 4 years. And if you look at where that fits in terms of cancers, the only thing has a worse survival is lung cancer. And so you'll understand that when patients get a diagnosis of IPF and they go look it up, which they tend to do, and they Google it, they're scared. I mean, they're reading that they're going to be dead in 3.5 to 4 years. So untreated IPF has a poor prognosis. Pushing us to diagnose it earlier and get them on therapy. So here are the diagnostic criteria for IPF. You have to exclude all other causes of ILD. So this is critical. You can't have rheumatoid arthritis and IPF. You can't have scleroderma and IPF. So, because if you have those, you have a known cause of ILD. So first off, you have to exclude all other causes of ILD. You have to rule out connective tissue disease, make sure they don't have birds or mold in their house, make sure they haven't taken drugs such as methotrexate or nitrofurantoin. And then they have to have a pattern on the HRCT of UIP. And if they don't have that, they have to have specific combinations of patterns on pathology and HRCT. So you can see at the bottom there, if you don't have a definite UIP pattern, which we'll obviously talk more about, and you have a lung biopsy, we look at the combination of patterns on lung biopsy and pattern on HRCT to come up with the diagnosis. Unfortunately, if you have indeterminate patterns on both, then your diagnosis is indeterminate, and we do see that sometimes. This is our diagnostic algorithm for IPF. And so this is really helpful to know what we go through and where the chest radiographs and the HRCT comes into play. If we suspect IPF and they have a known cause, clearly, as I mentioned, they don't have IPF. If you think they have IPF and you find out they have rheumatoid arthritis, that is not IPF. But if they don't have a known cause, then you get your HRCT. And if you have a UIP, a definite UIP pattern, which we'll go over later in the talk, you bring it to a conference, the multidisciplinary discussion. That is a conference that's critically important. That includes a radiologist, pathologist, and the pulmonologist. And then that often leads to an IPF diagnosis. If you have any of the other patterns, probable, indeterminate, or alternate, you have a discussion, and that often leads to either a surgical lung biopsy plus or minus a bronchoalveolar lavage, and then you bring it back to that conference and try to come up with the best diagnosis you can. When you're working these patients up, we obviously get lung function testing, and what we tend to see is restriction. So they have small lung size, their gas exchange is poor. This goes along with interstitial lung disease. We check oxygen saturations at rest and with exertion. They often desaturate, and they invariably desaturate later in the course of their disease. We keep in mind some of the risk factors that are associated with these diseases, such as smoking and a family history and age, as we mentioned before. I want to mention briefly interstitial lung abnormalities. There was a Fleischner Society position paper in Lancet Respiratory with David Lynch as a senior author in 2020, really clarifying for us what this term means and how these are significant. So the clarity in that article is that interstitial lung abnormalities are incidentally found interstitial changes on chest CTs that are not done to screen for ILD, so done for other reasons, done for lung cancer screening or to rule out a PE. And so when you see interstitial changes on those scans, that's what is termed an interstitial lung abnormality. There are a bunch of different subcategories. So there are, ground glasses in there, but so is traction bronchiectasis, reticulation, honeycombing. And the key take-home message, and I think this is probably the most important slide here, is that these progress. And so there's plenty of data to show that when you have these interstitial lung abnormalities, that they're associated with functional impairment and they're associated with progression, especially the fibrotic ones. So when you have fibrotic changes such as reticulation, traction bronchiectasis, and honeycombing, these patients progress over time. They have a worsened outcome, an increased risk of death. And if you biopsy them, you'll see UIP patterns on histopathology. So these mild changes that we're seeing on CTs, that are these incidental changes, are critically important to bring to the attention of the ordering provider so that they don't get forgotten and they get worked up. These patients will progress over time. So I want to stress that these ILAs are important, and we'd love to hear about them so we can follow these patients in clinic. There are some approved antifibrotic therapies, and I'll end on these. 2 of them have been approved for IPF since 2014, nintedanib on the left and pirfenidone on the right. And then there have been other trials. I'll mention the census and INBUILD trials with nintedanib briefly. And pirfenidone is in a couple ongoing trials. There's a SLS3, which is looking at pirfenidone in scleroderma. The RA-ILD trial is about to finish. And then there was a PF-ILD trial in pirfenidone that didn't meet its primary endpoint. But for IPF, these trials were published in 2014, and these are effective therapies. And they're similar in terms of their efficacy. So these are the data for nintedanib. This is an IPF. This is a 52-week trial, so both trials were a year. And if you look on the y-axis, this is the change from baseline in the vital capacity. And patients on the top line are with nintedanib, and the bottom line were placebo. And you can see that on nintedanib, you had a slower decline with a difference of about 110 cc's over that year. So definitely slows down decline. Similar take-home message with pirfenidone. We also saw a change in the decline over time over a year. And so again, take-home message, you decline slower. You still declined, but you declined slower when you were on that drug. Both these drugs have had follow-up studies showing that mortality is improved, but there was no mortality benefit in those original trials. In the census trial was looking at nintedanib in scleroderma ILD. So on the right there, you can see a similar to what we saw in IPF, that placebo patients declined over time about 100 cc's. They lost over a year, and when you got put on nintedanib, it cut that in half. And so you see these similar effects in other progressive ILDs. And then interestingly, we just got results last year of the INBUILD trial. And what this trial did was took patients with progressive fibrosing ILD. So it didn't matter how you got there if you had progressive fibrosis over time, and there was a definition in that trial of what that meant, but it meant progression either radiographically or symptomatically or through physiology. Doesn't matter what caused your ILD. If I put you on nintedanib, you had a benefit. And so this shows the overall population, and you can see that graph that in the overall population, there was a benefit to being on nintedanib over 52 weeks with decline in vital capacity. And that benefit was most significant in patients who had a UIP-like fibrotic pattern on CT, but even the non-UIPs benefited from nintedanib. So what we're learning is that if you're progressing over time, maybe it doesn't matter specifically what your insult was. If you have progressive fibrosis, you should be on an antifibrotic. I will mention briefly COVID-19. You all are probably seeing a lot of scans from COVID patients. We're doing a couple studies with them looking at the fibrosis. These patients clearly, a lot of them have respiratory failure that's prolonged, and so they'll have those anterior changes from just ARDS being on a vent. But we're also seeing basilar and peripheral predominant fibrosis, as you can see on this scan. after COVID. And we're studying these patients. And does it resolve at a year's time? We don't know yet. We're hoping it does. In SARS and MERS, we did see resolution in those changes. But what is it? What's causing it? Is it just prolonged mechanical ventilation? We're not sure, but we're going to be seeing a lot more of these patients, obviously, as we're seeing the survivors of COVID-19. So key messages for this section of the talk is that there are multiple causes of shortness of breath. Common things being common, COPD, asthma, heart failure, they're at the top of the list, but ILD can get missed because it's less common, but an important to be diagnosed early because when they progress, their progression's permanent, and we have drugs now that can slow their progression. And the elements of the diagnosis that are critical is a full history exam, PFTs, and imaging. We put all those together and to get that diagnosis. We have a brief time for, there's some audience questions that I'll address quickly before we move on to the next section. One question is, discuss the efficacy of antifibrotics at lower doses when full doses are not tolerable. Great question. These antifibrotics have side effects that we, with changing when you take the medication and how you take it with food, you can often mitigate, but when you don't, you can dose de-escalate. And both of these drugs have a dose response curve. So we feel comfortable treating them at lower doses. We think that the response is probably lessened, but it is better than being off drugs. So we often dose de-escalate to try to keep patients on these drugs. And then a second question, is there any evidence that besides slowing down progression, antifibrotic therapy increases vital capacity? Unfortunately, they do not. So we don't see any improvements in vital capacity. These do not reverse fibrosis. So unfortunately, we're not at the stage we can reverse it. The best we can do in these patients is slow down or stop the progression, but nothing is reversing their fibrosis. And with that, I'll turn it over to my colleagues.
Thank you so much, Dr. Solomon. That was a great introduction to the clinical approach to ILD and a little bit about the treatment and antifibrotics. So thank you so much. And now I'm going to turn it over to Dr. Mary Salvatore, radiologist, and we're going to turn things a little bit around and focus more on imaging, and particularly imaging in the multidisciplinary approach to diagnosis. So Dr. Salvatore.
Thank you very much for the opportunity to speak today about the radiology of lung fibrosis. I'm going to start with these two images. Which patient here has pulmonary fibrosis? The one on the right or the one on the left? That's easy for us to say that the one on the right is pulmonary fibrosis. But what if you had to teach a medical student how to recognize fibrosis? You might start by talking about Hounsfield units. You know that water has 0 Hounsfield unit. The normal lung is minus 850 Hounsfield units because it's darker than water on CT scan. Emphysema, because there's more air in the lung and making the lung more darker, is minus 950 Hounsfield units. And in contrast, pulmonary fibrosis is making the lung wider, around minus 400 to minus 600 Hounsfield units. What is making the lung look wider on CT scan in pulmonary fibrosis? This is an electron microscope from Dr. John West, who allowed me to share it with you. We see a capillary with the red blood cells. Outside is the alveoli, and we see the interface between the capillary and the alveoli. The fibroblast foci is the bad guy in the pulmonary fibrosis, and when it gets excited, it lays down collagen between the capillary and the alveoli. And you can imagine that would cause the lung to become wider, the CT scans to become wider. This is another slide from Dr. West where he shows a terminal bronchus and the alveoli surround it, and he explains that the alveoli hold the terminal bronchus open. With fibrosis, the patients have decreased alveolar epithelial type 1 cells and then ultimately decreased type 2 cells, which produce surfactant. The lack of surfactant causes the alveoli to become atelectatic, which pulls open the terminal bronchus. So then it's not surprising that the earliest features that we see on a CT scan of a chest in a patient with fibrosis are ground glass opacities, representing a combination of collagen deposition and atelectasis, and these black holes, which are dilated bronchi, traction bronchiectasis, caused by radial traction on terminal bronchi from atelectasis of the alveoli. It's great when we have guidelines. The American Thoracic Society has provided us guidelines for the confident radiographic diagnosis of UIP. And this is a very important task for us as radiologists. We need to look for the criteria, and when we see them, we need to say that we see them confidently, because it has important implications for patient treatment. So the guidelines say that we have to have a subpleural basilar predominant fibrosis. That's the S. And that's probably the most important thing. Fibrosis of UIP is peripheral, and nothing else, essentially. Maybe asbestosis is peripheral. So when we see a peripheral fibrosis, it's most likely to be UIP. Again, like Dr. Solomon said, though, it could be UIP associated with rheumatoid arthritis or UIP associated with IPF, but it is a UIP pattern when it is peripheral and it's basilar predominant. Basilar predominant, other things are basilar predominant, though, so it's not the most helpful sign. The most helpful sign is that it's subpleural. So S, subpleural basilar predominant, R for reticulations, which are linear densities represented in thickening of the interlobular septa. The H is for honeycombing, an important feature of UIP, but seen in other diseases when they are present for a long period of time. And absence of features that would suggest an alternative diagnosis. So we have SRHA. Some radiologists have all the answers because they attended this lecture. And what if we don't? Oh, honeycombing. This is honeycomb. This is a wall in Ireland. My family's from Ireland. If you've visited Ireland and seen these walls, the farmers clear their fields of stones and they put them on the ground, and then they stack them on top of each other. And just like these stones touch the ground, honeycombing has to touch the pleural surface. And no good farmer is going to leave his stone wall only one layer of stones thick. They're going to stack them on top of each other. So I wait till I see at least 2 stacked cysts. There's probably honeycombing pathologically earlier, but if I say it too early, I might be mistaking it for paraseptal emphysema. So I want to see cysts that touch the pleura and that at least one of them are stacked on top of the other to call it a honeycomb pattern. If there's no honeycombing but everything else is present, then we call it a probable UIP pattern by ATS criteria. And that alerts the clinician that the patient, they're going to take a good clinical history, like Dr. Solomon explained, and decide whether a biopsy will be necessary. So absence of features that would suggest an alternative diagnosis. When I saw this list, I thought of the mnemonic cannot be. It cannot be UIP if there is C, consolidation. If we see a lot of consolidation, we think about organizing pneumonia and acute interstitial pneumonitis. If there's A, air trapping, we're going to think about hypersensitivity pneumonitis. N for nodules. If there are a lot of nodules, we're going to think about sarcoidosis or acute hypersensitivity pneumonitis. Another N for non-solid or ground glass opacities. If we see those, we think about respiratory bronchiolitis, interstitial lung disease, and DIP, discriminative interstitial pneumonitis. I would have liked to have had a C here, but I had an O, so an O looks like a cyst, so I'd like you to just improvise with me. If there are a lot of cysts, we're going to think about lymphocytic interstitial pneumonitis, but we're not going to think about UIP. UIP is basilar predominant. If we see fibrosis in the top of the lungs, it's not going to be a UIP pattern. It's going to be something more like a hypersensitivity pneumonitis or sarcoidosis. B is for bronchovascular. UIP is peripheral. If we see a disease that's bronchovascular, it's not going to be UIP. I was frustrated, I think, in about 2015. I heard that radiologists can't get the right diagnosis of pulmonary fibrosis a lot of the time. But I was encouraged when I read Maxwell Smith's article on the pathology of pulmonary fibrosis. He gave these beautiful diagrams, and I understood then when I saw pathologically what it looks like, why I'm seeing what I'm seeing radiographically. So I called him up and I'm like, I have to work with you on this. This is so interesting. So he draws the secondary pulmonary lobule to look like this with an artery and bronchus in the middle and the alveoli, normal lung. UIP is a peripheral disease. It's peripheral within the secondary pulmonary lobule, and it's peripheral within the lung parenchyma. It's heterogeneous, it's scalloped. That's the hallmarks of UIP. So it's not surprising then that we see the disease of UIP as being peripheral, and that's the most important feature. I'm going to show you some cases in a minute. You ask yourself first, is it peripheral? And if it's peripheral, it's UIP, and you can go forward. It's most likely UIP. In contrast, NSIP pathologically has thickening of the alveoli diffusely. So it's a much more homogeneous disease. Unlike what UIP is peripheral, NSIP follows the bronchovascular bundles and is a more homogeneous disease. It is like UIP in that it is lower lobe predominant. So we have to use other features to make the diagnosis. This has a lot of ground glass opacity. So if I was describing this radiographically, I would say it was on the spectrum of more of a cellular NSIP and might be more responsive to steroids. The patient's esophagus is dilated, so I'm going to suggest that this patient has cellular NSIP and probably scleroderma. Airway-centered fibrosis occurs around the airways. So here we see that the areas that represent minus 400 to minus 600 Hounsfield units are around the airways, and that there are areas of air trapping. You can imagine if you inhale an antigen, it might cause some airways to become narrowed and in spasm and cause air trapping. And those secondary pulmonary lobules, because the antigen can no longer get in because there's air trapping, are going to be spared of the fibrosis, whereas along the airways, there's going to be fibrosis. This is traditionally called the head cheese sign, which recently has been renamed to have three densities: the low Hounsfield units, the high Hounsfield units, and the normal Hounsfield units of hypersensitivity pneumonitis. So let's look at a few patients and see if we can figure out what the diagnosis is. We have a patient here. First question you should ask yourself, is the disease peripheral, the fibrosis peripheral? It's not peripheral. In fact, and it's not homogeneous, so it's not NSIP. This is a fibrosis around the airways, so we're going to ask this patient if they have mold or if they have down comforters, and they're going to need to get rid of those. In contrast, this patient has fibrosis. We ask ourselves, is it peripheral? No, it's not just peripheral. It's central around the bronchovascular bundles. The next question, is it homogeneous? It's homogeneous. So this is going to be an NSIP pattern. There's a lot of ground glass opacity. There's peripheral sparing. That's helpful when it's present, but it's only present in about 46% of the patients, so it's not always helpful. So this is cellular NSIP pattern. Here we see a fibrosis. It's peripheral. There's honeycombing. So this is a UIP pattern. When you're giving a lecture, you should wait a full 5 seconds for an answer. I never want anyone to feel stressed, so I always tell you the answer right away. I'm sorry, I don't mean to do that to you, but I don't want you to be stressing. This is a little bit complicated case. First, we look at a fibrosis. We see the areas that are minus 400 to minus 600 Hounsfield units. We notice that they are not just peripheral, so this is not a UIP pattern. It's not homogeneous, so it's not characteristic of an NSIP pattern. We see that the fibrosis is airway-centered. There's mosaic attenuation. So this is airway-centered fibrosis compatible with chronic hypersensitivity pneumonitis. When you look at this one, this is going to be best for nonspecific interstitial pneumonitis because it's homogeneous. But unlike the other ones that didn't have as much bronchiectasis, this one has ground glass and bronchiectasis, so it's going to be mixed cellular and fibrotic NSIP pattern radiographically. And notice all the volume loss, which is so characteristic of NSIP. The major fissure is usually more anteriorly, and it's been displaced as well as the rest of the right lower lobe. Here we see a patient that has airway-centered fibrosis. We're going to ask this patient to get rid of their animals, their birds, their down pillows, and this is compatible with chronic hypersensitivity pneumonitis. Here we see a fibrosis with peripheral sparing, homogeneous. This is not a UIP pattern. This is an NSIP pattern. How about this patient? The first question we ask yourself, is it peripheral? It is peripheral. We see cysts stacked on top of each other, so this is a UIP pattern by ATS criteria. We should just say that there's no differential for this, and the patient then can get their treatment. So it's important and nice to make the right diagnosis. Important, not beyond nice, important for the patient for us to make the right diagnosis radiographically if we can. And again, it's only one part of the multidisciplinary discussion. So I'm just expected to say what I think is the best radiographic pattern. The clinician is going to look clinically at what's the best presenting symptoms for the patient and what's most consistent with, and the pathologist is going to do the same. And it's the discussion together that is most important. But as a radiologist, we have an important role in saying what we think is the best diagnosis. Another thing that we need to remember is about progression. It's probably not enough for us as radiologists to say that the patient has a little disease and it's getting a little worse. Ideally, we should be more specific in the diagnosis, but there's not a readily available scoring system. A lot of computer tools are being used to quantify fibrosis, but they are not quite available for everybody. So in the meantime, quantifying fibrosis by a simple grading system would be helpful. That needs to be validated. I have worked with quantifying fibrosis on a scale of 1 to 16 in some of my research, and that has been helpful. But I had a new idea that maybe instead of quantifying the amount of fibrosis, it would be more optimistic to quantify the amount of normal lung. And so a 5 for a lobe would be totally normal, and then a 0 or 1 would be 50% of the lung is left as normal. And that's good because then as the grade decreased, it corresponds well with the DLCO, which when we grade fibrosis on CT scan, it always parallels better the DLCO than the forced vital capacity. And so with this research, I have looked at quantifying normal lung and comparing it to the percent DLCO with promising results. We looked at 96 patients. They were on average 71 years old. And they had a variety of some very sick people and some relatively well people. And the percent of normal lung corresponded very well with the percent DLCO. And it's kind of more optimistic, right? We're going to treat because we're going to preserve normal lung as opposed to prevent fibrosis. I don't know, just that way. When we talk about progressive fibrosis, which is an important topic that Dr. Solomon had spoken about, we can say that fibrosis are increasing the extent of disease, so the disease is getting worse. But sometimes other parts of the CT scan can allude us to progressive fibrosis. Like we can go from a cellular NSIP pattern to a fibrotic NSIP pattern, and that's progression of disease. Or we can go from acute hypersensitivity pneumonitis to a chronic hypersensitivity pneumonitis pattern, and that's progression of disease, yet the amount of disease may not have increased. Another thing that is a way to look at progression, which is kind of novel, and I want to share with you, is that if we look at the right upper lobe bronchus, which to me looks like a goldfish cracker, I don't think you'll look at goldfish crackers or the right upper lobe bronchus the same again. And if we put a line from the sternum to the spine and a line through the nose of the fish and its tail, on 100 people, this angle was 90 degrees on average. Look what happens with hypersensitivity pneumonitis. The fibrosis is typically in the front and pulls the fish's tail anteriorly, which makes that angle more shallow. In contrast, sarcoid, because it's in the upper lobe posterior, pulls the right upper lobe bronchus posterior and increases the angle. And the greater the angle is increased, the more fibrotic the sarcoid is. And I have looked at that with NSIP and sarcoid with good results with sarcoid and CHP. In addition, the right lower lobe bronchus becomes progressively posterior displaced with NSIP, which also marks progressive disease. So we talked about how to diagnose the most common types of fibrosis, UIP, NSIP, and CHP, to differentiate them. We talked about quantifying fibrosis and saying whether it's progressing or not, whether it's by extent of disease, stage of disease, or the volume loss. And we have some questions to think about. And I'll take the one for, how do you distinguish UIP from chronic HP? We're fortunate to have definitive diagnosis for UIP, which is subpleural basilar predominant fibrosis with honeycombing and absence of features that would suggest an alternative diagnosis. With chronic HP, it's not peripheral, it's airway centered. Mosaic attenuation is a very helpful feature for hypersensitivity pneumonitis as well, which is not seen in patients with UIP. And what is... how do you establish a multidisciplinary group? A multidisciplinary group has a group of people interested in ILD, an experienced pulmonologist, an experienced pathologist specializing in pulmonary and ideally pulmonary fibrosis, and a radiologist and a rheumatologist is ideal to have as well. Thank you very much, and I'll turn it back to you.
Thanks very much, Dr. Salvatore. And I'd, add, you have to identify the right people and the people who are interested and have time. And it's best when you get together in the same room and can talk about these things back and forth. And we always gain a lot of information from each other. I learn a ton from people like Dr. Solomon about the clinical side and from pathologists. So we really can learn a lot from each other. And that's one emphasis of, I think, this session. So let's move on to the practicum. And so my goal with choosing this specific case was to choose something that was not super straightforward. I mean, If you have someone who has central lobular ground glass nodules and has a bird, that's not a very challenging diagnosis. But I think we're most challenged with these cases where the diagnosis is not entirely clear or the biological behavior is not entirely clear. So again, this the multidisciplinary approach involves this sort of steps, right? We take a history and clinical, and almost everyone's going to get both spirometry and an HRCT. And if you can make a confident diagnosis by incorporating all those together, then you're basically done, and you can just determine treatment and evaluate patients over time. And over years, that has become a greater percentage of patients. I think in our institution, we get fewer biopsies, many fewer biopsies than we used to. But still, if we're not able to make a confident diagnosis, then we do additional treatments such as, well, surgical lung biopsy is the more definitive treatment, but we can also do additional things that are kind of in between, such as bronchoalveolar lavage, looking for lymphocytes for HP, transbronchial biopsies, cryobiopsies are becoming sort of a hot topic these days. So this is our general approach. And again, I think it's really helpful when everyone gets together and can discuss these cases and can have a back and forth about these cases. And again, we always gain a lot of information from each other. So that's the general approach, and I encourage anyone who's interested in ILD to take this approach and to develop a team together that is interested in this area and has expertise in this area and can really talk to each other about these cases. So I wanted to do that today between the three of us and talk about a specific case. So this was a 53-year-old woman who was presenting with a cough and did not have dyspnea at this time. She was a non-smoker. Her only exposure was a down comforter, and she had no signs or symptoms of connective tissue disease. So Dr. Solomon, I'm going to start with you, and this isn't a ton of clinical information, but it's a reasonable, there's some interesting clues here. How would you approach a patient incorporating all this, the age and the exposures and et cetera? What would be your approach to this patient? What would be your sort of suspicion of the most likely diagnosis that you'd be thinking about even before looking at the HRCT?
Sure, thanks. Sure, so age and gender are important. So, I talked earlier about IPF and some of the fibrotic ILDs being more common as you age, but 53 in my world is young. So this is a young, and it's a young female. And so really, and I like that you put no signs and symptoms of a connective tissue disease. When they walk in as a young female with something suggestive of ILD, connective tissue disease is at the top of that list. And as I mentioned, some of them will have the ILD before they have the connective tissue disease. So that would be on the top of my list. Non-smoker helps. I mean, smoking is a risk factor for IPF. And smoking actually, non-smokers are actually a little more likely to get HP. Smoking can suppress granuloma formation. So non-smoker helps some, and then we always ask about exposures. And as I mentioned, bird feathers are a big one. So that exposure obviously puts HP up there also. So I think the top two on my list would be HP and connective tissue disease, and I think something like idiopathic pulmonary fibrosis would be much, much farther down given the age, gender, non-smoker. Gotcha.
And so a couple of follow-up questions to that. One is, certain exposures are really strongly associated, others are maybe not as strong. Can you talk a little bit about down comforters and other exposures and how much that's going to push you towards HP or push you away to something else?
Sure. The exposures are hard. You're right. There are some really strong exposures. So birds and bird feathers are really strong drivers of HP. And interestingly, a study came out a few years back looking at a bunch of patients that were initially diagnosed with IPF and looked at those who were, went back and looked at these cases, and the ones that were misdiagnosed, the most common ones that were missed were HP, and the most common precipitant was down. So down is actually, down's very common, especially where I'm at in Colorado. Everyone has down. And so the presence of down just brings HP a little farther up, but you need to investigate further. I mean, the other things, some of the some of the molds that we see in houses that are real subtle and sometimes they're hard to find, those are less strong drivers. But when I see bird feathers in any fashion, either be a live bird or down, HP climbs its way up the differential.
Yeah, our pathologist always likes to talk about how the longer you have down, the more likely it becomes antigenic over time, which I thought was really interesting. That's something I didn't know until recently. And then the other follow-up question is, in terms of connective tissue disease, like serologies, panels of serologies, how do you get those in all patients? How do you use those?
It's a great question. If you look at the old guidelines for IPF, they said, you should get an ANA and a rheumatoid factor, and there's still some people who do that. But take into account that all connective tissue diseases can present with ILD and can present with ILD first, then we always do an extensive screen. And so if you come in our clinic and you have ILD, you can be an 80-year-old male, I'm still screening you. And we often will find evidence of serologic positivity, and then that leads to a referral to rheumatology. There are features of connective tissue disease that are very subtle. So nail fold capillaroscopy and scleroderma, that's something I don't do, and that can make that diagnosis. And so that's why if there's anything, we do a full screen. If there's any positivity, we send them to the rheumatologist, and sometimes it's a false positive, but oftentimes you'll find either subtle or a not fully developed connective tissue disease. So to answer your question, full serologies on everyone is what we do.
Okay, yeah. All right, so let's move on to the CT scan, since we're radiologists mostly viewing this symposium here. So Dr. Salvatore, how would you approach this CT scan? Can you tell us a little bit about the findings and then what your most likely diagnosis are going to be?
So when I look at this, I'm going to look for the areas that are minus 400 to minus 600 Hounsfield units. I'm going to first ask, is that pattern predominantly peripheral, which it is not? The next question I'm going to ask myself, is it homogeneous like NSIP? And I'm going to have to say no to that as well. The high density areas are around the airways, and I see evidence of mosaic attenuation. And I use that term because this is an inspiratory CT scan, and I would need an expiratory CT scan to say if it was air trapping or not. It's important that we use thin section CT scans to make these diagnoses. But given the CT scan images, I think that it's best for an airway center type of fibrosis like chronic hypersensitivity, pneumonitis. I'm saying chronic, but there's a lot of ground glass. So, and there's not that much bronchiectasis. So it would be more of a subacute hypersensitivity pneumonitis pattern radiographically.
Right. So according to the ATS criteria, we would probably classify this as suggestive of an alternative diagnosis. And I guess one question I have for you is that still, the literature suggests about 25% of people who are considered suggestive of an alternative diagnosis still have IPF. So are there certain features that are really going to push you away from IPF over others?
So the air trapping is very helpful. Usually when you see air trapping, and if they happen to have UIP, it might be rheumatoid arthritis, which could have air trapping, but it's very uncommon with the UIP-IPF, and the ground glass is another feature that should steer me away from UIP-IPF unless they're having an exacerbation.
Right, okay, great. So would we need a lung biopsy in this patient? I mean, throw it back to Dr. Solomon here. Would you do a lung biopsy? I mean, obviously there's a lot of things that go into that, whether the patient can tolerate it and patient preference and comorbidities, but in general, if the patient was a good candidate and willing, would you have done a lung biopsy in this case?
Yeah, so as you astutely noted, we are doing very few lung biopsies these days. And part of that, it also depends on where you practice. We are, if you're at a tertiary referral center, an ILD specialty center, you're much less likely to do biopsies because you have the benefits of radiologists who specialize only in this and pathologists. So, you have a patient with a appropriate clinical history, with an exposure, and as you pointed out, a scan that's typical for HP. We would not do a biopsy in this case. One thing you could consider is you can consider a bronchoalveolar lavage. You mentioned earlier lymphocytosis. So if you wanted to just move yourself a little closer to definitive diagnosis, you lavage these patients. If you see anything above 30% lymphocytes on lavage, 25 to 30%, that really helps you really confirm that this is an inflammatory chronic inflammatory disease, and HP fits really nicely. So I think most likely this patient would not get a surgical lung biopsy at this stage.
Yeah, and that's exactly what happened. The patient was presumed to have hypersensitivity given the presence of an exposure and a very typical HRCT. The patient was put on prednisone for a year. The cough and all the symptoms completely resolved. She kind of got lost to follow-up, stopped the prednisone, wasn't heard of for a few years, and then came back because she became dyspneic and had a follow-up CT scan. So Dr. Salvatore, can you tell us about the changes between the baseline and then the 6-year follow-up?
There is increased traction bronchiectasis, and the extent of disease is increased. It's become more fibrotic and less acute, with less ground glass and more traction bronchiectasis, and more air trapping. And look at how the fissure is moving backwards. There's more volume loss, so there's been progression of fibrosis, and still the features are similar and the air trapping is still present, so the mosaic attenuation is still present. So I would say more of a subacute to chronic hypersensitivity pneumonitis at this stage.
Right. Yeah, and that's what we thought as radiologists, but our clinical people are very focused on IPF, particularly given that we have very specific treatments for idiopathic pulmonary fibrosis. So I think they have at least our people have become a little bit less willing when fibrosis progresses. They are a little bit less willing to just accept our diagnosis of HP, which is what I totally agree. I think this is still very likely going to be HP. And so, because they want to make sure if this is progressive fibrosis, even if it is HP or some other disease, you still could use one of the antifibrotic agents. So they decided, just since the down was an exposure, but wasn't like a really close exposure, like a super suggestive exposure of HP, even though it clearly is associated, and mostly the fibrosis had progressed, they decided to do a lung biopsy at this time, which might be a little aggressive compared to other places, but that's what happened in this case. And I think it was helpful in this case because we're going to have both a VATS lung biopsy, right? And in most patients, in our patients in particular, we try to get 3 samples from 3 different locations within the lung to sort of get a good sampling of the lung. But you have to remember that VATS lung biopsy is still just a sampling, and one of the advantages of CT is it gives you the whole lung. And then we actually get an explant later when the patient gets their transplant. So the lung biopsy, these are all features of usual interstitial pneumonia. Subpleural, kind of patchy, heterogeneous fibrosis with microscopic hunting fibroelastic foci, and it was not on the VATS bronchial-eccentric. And so what do we do with this now, Dr. Solomon?
Yeah, that's a good question. I mean, we get surprised a lot of times at biopsies, and that's and part of that is that we only biopsy we don't biopsy cases that are clear cut, right? We biopsy cases that we don't know what's going on. So, and you're right in that we oftentimes will find UIP on biopsy, and I think that's helpful. So this, the one question I would have is sometimes we have patients on therapy when we do the biopsy. So if this patient came back and got put back on prednisone and then biopsied, prednisone may suppress or get rid of some of the more inflammatory findings that would change this diagnosis. But if you have a expert pathologist telling you this is UIP, and UIP needs to be treated with an antifibrotic. So, and the other thing to consider is potentially there's a sampling error, right? I mean, I know you said we get 3 different sections, and we do that, but you're still sampling a lung. And so you may just have sampled an area where you don't see other features that suggest something other than UIP. And the final thing I'll mention is a lot of times we'll see areas of the lung in certain lung disease where it has UIP in some areas and we see NSIP in other areas. Those patients still don't do very well. But you could also see HP in other areas. So again, sampling error is possible, but this is what you got, and this looks like UIP.
Great. Okay. Yeah. So here's the full follow-up. So before we get into this, Dr. Salvatore, I want to go back a little bit, mention a little bit more about the role of CT in the follow-up of patients. I mean, I think our clinicians sort of focus on pulmonary function tests and symptoms as a primary way of following patients. So can you talk a little bit about how we use CT in the interval follow-up of patients and how it relates to pulmonary function tests?
I think it's helpful information to the clinician when a radiologist can say that the extent of the fibrosis is getting worse, especially if they're on a certain treatment, and then they can have that information that treatment is not working and that they might want to change gears. I think that if you see the 8-year follow-up CT scan here, it's very hard to say what the diagnosis is, and I usually rely on the first CT scan for the pattern of fibrosis, and then the change over time. Once it gets to be 8 years after, everything begins to look very similar and hard to make a diagnosis. But clearly it's progressed, not only in the extent of the disease, but the stage of the disease has progressed.
Yeah, right. That's a great point. Like often the first CT is the most diagnostic, although, as was in this case, I guess at the same time, occasionally the follow-up CTs are more diagnostic, particularly when we see early UIP and it's early on, you just have a little bit of fibrosis. It may classify, you may think it's ILA, interstitial lung abnormality, but then later on they develop more advanced fibrosis and honeycombing. But I think that's a great point that often the first CT is the most diagnostic. And when it gets to this point, it's hard to tell what it is. I mean, I probably would have called the 8-year follow-up CT classic UIP, but that being said, on the baseline, it was sort of classic hypersensitivity. So this patient was put on antifibrotics at some point eventually. It was probably too late at that point, and they continued to progress. And they eventually got a lung transplant, and surprisingly, the lung transplant showed findings that were pretty typical of hypersensitivity pneumonitis with fibrosis. And as many people, as some of you are probably aware, the American Thoracic Society has recently put out a new consensus paper on approach to hypersensitivity, and they're recommending that we sort of transition to active inflammatory HP versus fibrotic HP as the two categories. So this would be classified, at least now at this point, as more of a fibrotic HP. Although there were probably there are still fibroblastic foci, which are a little bit more UIP-like. So there's an overlap, but I think the final diagnosis in this case was a case of HP that was kind of biologically behaving like UIP. So Dr. Solomon, can you talk a little bit about that and maybe how we're maybe transitioning to a different paradigm on how we even approach ILD, and maybe it's not as diagnosis is as important as biologic behavior?
Yeah, that's a good question. We don't like these cases because we see these patients with HP who they start progressing like IPF or UIP IPF, and actually some of these HPs, by the time they come into us, we only have that last scan. And so this shows you how a lot of these, you can go back and look at some of these IPFs and you learn that they actually were something else before. And by the time they get to you, they have an end stage scan with a UIP pattern with a lot of honeycombing, and you really don't know what got them there. And so we do see these HPs that will progress and become fibrotic and need to get transplanted. But your point is a good one that with the INBUILD trial, which really took anyone with fibrosis and put them on an antifibrotic, and that trial included HP and included RA, and put them on drug that is an antifibrotic, that their progression slowed. So I do think your point is a good one, that maybe it doesn't matter how you get there. Once you have fibrosis, an antifibrotic should be considered. The one caveat to that is if you can, if it is HP and you can determine that, you can, removing the exposure can be sometimes helpful. So we still go back and look to see. We don't just throw everyone on nintedanib because they're progressively fibrotic. We do go and try to figure out what the initial cause was. But at the end of the day, if you have progressive fibrosis, I think you should be on an antifibrotic. Doesn't matter how you got there.
Yeah. And I think that another important thing to keep in mind as radiologists is that the criteria for UIP are designed to be specific, but not necessarily sensitive. So there may be features that are going to, not be definitive of UIP, and that's fine. And that's when we get a lung biopsy to try to come up with a definitive diagnosis. Although, as in this case, you see how lung biopsy is not the gold standard. The gold standard is the multidisciplinary approach. So a few last questions I wanted to talk about. I mean, Dr. Salvatore, protocols come up a lot. So what is your standard HRCT protocol? How does it compare to your routine chest CT without contrast? And, how do you use prone and expiratory images? Can you talk a little bit about that to our radiologists?
So the first CT scan, the initial CT scan, should be performed without contrast, because contrast, when it goes in, it makes you feel warm all over, makes you tachypnic, and that's the enemy of a good interstitial lung disease scan. So a non-contrast exam performed at full inspiration. We want to use thin sections, 1.25 millimeter, and or less, to evaluate the traction bronchiectasis and the reticulations. For our first CT scans, we do expiratory imaging and expiration to look for air trapping in patients that might have hypersensitivity pneumonitis. We rarely need prone images because unless it's such an early disease and we're wondering if it's atelectasis. But usually, if we don't see traction bronchiectasis, we'll assume it's atelectasis, and if we see traction bronchiectasis, we know it's fibrosis. But if there's a question, maybe twice a year we do prone images. So non-contrast is inspiration and expiration on the first CT scan. The second, we only do inspiration.
And do you use volumetric or skipped sections as your routine?
So, pardon?
Did you use volumetric or skip sections?
Volumetric, we go through the whole.
Volumetric, right. So almost all places have gone over to volumetric. And what's is a routine non-contrast chest CT good enough to evaluate for ILD? That's a question that often comes up for us.
If the slice thickness is 1.25 millimeters or less, it's fine. All of our CT scans are 1.25 millimeter and less, so I can use a lung cancer screening CT scan, which has a high likelihood to show pulmonary fibrosis, as long as there's no motion and there's good inspiratory effort. And less than 1.25 millimeters, all CT scans should be good for diagnosing ILD.
Yeah, I'm always surprised how many places still go with 2.5 or 5 millimeters in their routine. I mean, our routine is actually 0.625, and I think it's really I mean, you can evaluate all kinds of ILD on that without any problems. The only thing you lose is the expiratory images, which are not infrequently helpful. I think we touched a lot upon the use of anti-inflammatory and anti-fibrotic agents. That was the second question, and when they're useful and when to consider one or the other. We did touch a little bit on pulmonary function tests versus HRCT. I think that at our place, pulmonary function tests are used primarily to follow patients, and HRCT is used more for problem solving in patients who are getting worse, where you're wondering if it was worsening ILD or they have some superimposed process. I think it's also very helpful in patients who are unable to cooperate with pulmonary function tests, or the pulmonary function tests are not particularly thought to be accurate in those specific patients. All right, well, it's a great discussion. I think that we're sort of out of time, and I'd like to thank both of our panelists and lecturers for being here, and thank everyone for putting this together. Thank you so much for your attention, and I hope you enjoyed this session and have learned more about diagnosing early ILD, interstitial lung disease, and the multidisciplinary approach. So thank you again.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer View Institute for Medical Education.